Welcome to the Syndromic Insights podcast, brought to you by the World Society for Pediatric Infectious Diseases. We're your hosts, Dr. Linny Phuong.
And I'm Dr. Alicia Chang.
The goal of this podcast is to highlight how syndromic testing has changed how we practice medicine. Each episode will be exploring how these tools are transforming areas of pediatric care, from gastrointestinal and human rhinovirus infections to how AI and syndromic testing can be utilised to anticipate future health risks.
We'll be speaking to esteemed doctors and researchers around the world using real-life cases to inform your learning and understanding of these exciting developments. So let's start by defining really what is a syndromic testing. Why should we be using a syndromic testing over other tools? And how can we interpret the results? So I'll tell you, Linny, in my experience, syndromic testing has proven to be quite useful. I think is a way of making a diagnosis based on your patient's symptoms and try to focus your exploration, your laboratory, your imaging precisely in those on those symptoms, and it has really worked for me because I feel like it spares the patient from having a lot of tests that they don't need to be done, and also the patients feel assured, and they understand where I'm trying to get to.
Let's break down syndromic testing versus traditional testing. And then we can talk about some of those advantages that you mentioned of syndromic testing. So certainly the first thing is obviously with traditional testing, that is predominantly culture-based. So when we talk about traditional testing, we talk about doing, a viral culture or a bacterial culture. We might talk about using specific media. We might talk about using selective media. There might be some microscopy and gram staining, sometimes some biochemical tests even. And then the other sort of methods that we use with traditional testing is, as you will have used as well, serology, antigen antibody assays, ELISAs, Western blots, and then molecular testing kind of to a limited extent, as you've sort of said.
Really, this is all about trying to be minimally invasive and also super fast and super specific about our diagnosis.
Yeah, so you're right. So in terms of those advantages, we've kind of talked about a few already. So obviously the first thing is, as you said, like it's quick, less tests are involved. Also, I think one of the big advantages is that you can test for a wide range of pathogens. So you can do bacteria, fungi, and parasites all in the one test. Some of the things that a few of our speakers have talked about is the fact that, as you said, like you can provide reassurance to the parents or the patients because you are able to target and get an answer so quickly. And then I think the other thing that we haven't mentioned so far is just that improved workflow. So, being able to do those tests because it's a single test, whether in the lab or outside of the laboratory with, a nurse in clinic, for example, and also decreasing that hospital length of stay. I think that's really important too.
I would like to point out that there's also some weaknesses.
Yes.
And the main thing coming from a country where the resources are very, very limited is that this test may not be available widely in all countries where our listeners might be practicing, which it is a weakness, but at the same time, I think it's an opportunity because I think that you as a practitioner can identify from all of this variety of testing that we have available. Some are molecular testing, some are antigen testing, I mean, you can ask for them and bring them closer to you and to your patients. No, so maybe when you listen to this episode, you may think, oh, I don't have pneumonia PCR in my hospital. I don't have a respiratory panel. So, I mean, how is that going to be useful to me? But I think that we are trying to provide information and data, and we're trying to come together as a group of people taking care of kids, right? Kids with infectious diseases. To also go a little bit further and ask for the things that we really, really need at the end, even for very poor countries, this might be an intervention that will be cost effective.
No, I agree. And I think also it's worth thinking that even within sort of the more resource rich, I guess, countries, there is a lot of variation between what tests are available and what tests aren't. So definitely something that we should keep in mind. To kick off the series and dive deeper into syndromic testing, I spoke to Dr. Alfred Tam, a specialist in pediatric respiratory medicine based in Hong Kong. Our discussion focuses on a standard case study and introduces the value of syndromic testing to managing a child with a respiratory infection, as well as the impact on the healthcare system and further costs.
To improve your learning, listen carefully to the case presentation and imagine how you will approach it and what questions you will have for an expert. Let's check out your conversation with Dr. Alfred Tam.
Welcome to the Syndromic Insights podcast, Dr. Tam. We're privileged to have you here with us today.
Thank you. I'm very privileged and honored to be here.
So Dr. Alfred Tam is a specialist in pediatric respiratory medicine. He graduated from the University of Hong Kong and is currently the Director of Pediatric Respiratory Medicine at the Virtus Medical Group. He's also the Honorary Consultant Pediatrician at Kwong Wah Hospital, Honorary Clinical Associate Professor in Pediatrics and Adolescent Medicine at the University of Hong Kong and the Chinese University of Hong Kong. And he's also an Honorary Clinical Associate Professor in Family Medicine and Primary Care at the University of Hong Kong. Dr. Tam was instrumental in the establishment of the Pediatric Respiratory Medicine subspecialty in Hong Kong and was the first chairman of its subspecialty board. He's served on many pediatric respiratory and allergy societies and is an editorial board member of the journal Pediatric Respiratory Reviews. He has over 80 publications in peer-review medical journals and has delivered numerous local and international presentations. So today we're going to be discussing the benefits of syndromic testing in pediatrics. So Dr. Tam, before we begin, could you briefly explain the key advantages of syndromic testing compared to traditional methods of testing?
We used to see many patients with respiratory infections, and that's actually one of the sort of most common complaints that kids come to the doctor's office for. And of course, without the help of molecular syndromic tests, we basically have to examine the patient, do all those things. But with the help of the syndromic testing, we're capable of actually identifying exactly what virus actually is causing the problem. And we can then therefore hopefully give specific treatment if there is some, or at least to manage the patient with his symptoms and tell the parents what to expect with different kinds of virus.
Okay, no, I like that. And so just in terms of the workflow, do you feel like syndromic testing has helped you with that workflow?
Yes, indeed. I think we used to have this kind of syndromic testing done in the laboratory, and therefore it would require the specimen being sent to the laboratory or sometimes even to the hospital, and then all the process for it to be done, which takes a few hours before it would then eventually come back. But nowadays, with the advance of the molecular testing machines and technology, we're capable of actually having done in the clinic. And that actually becomes a very useful tool for the doctor to understand the etiology of the infection, and also to give parents the reassurance of what to expect and hopefully the right treatment if there is some.
Yeah, no, that makes sense. But can I just clarify, because obviously, Dr. Tam, many of the people who are listening to this podcast will be will have different experiences of syndromic testing. And a lot of us are often using PCRs in the laboratory. So what you're suggesting in your laboratory or your clinic is that you have a point of care PCR test.
Exactly. Yes. I mean,
Okay.
we all know, thanks to COVID, that the PCR technology has sort of taken leaps and bounds of advance, and therefore we are capable of testing many different viruses or different bacteria at the same time.
Mm.
But the point is that it would only be useful when actually when test and results comes in with a reasonable fast speed, so that the patient can be actually walking out of our office with a definitive answer. And therefore, it's the machine that actually helps, so that the nurse can do a swab and I put it into the machine, which is reasonably easy. And when it's fast enough, I mean, the machine that we have now can actually give a test result for a panel of 15 agents in 20 minutes.
In 20 minutes.
So, and that actually takes a lot of improvement in terms of
Yeah.
how the patient expect what to do and how the doctor actually advises the patient in terms of the management.
Wow, that's incredible. And so you're saying that these are actually nurse run tests. It's not a laboratory scientist. Basically, the same people that you have in your clinic are able to operate these machines.
Correct. It has become like fully automated. The only thing that we need to do would be to actually take this sample and then put it into a transport medium and then push
Okay.
it into the machine, and that's it.
Wow. Okay. And you said 15 different agents are tested. What are the 15?
Well, that includes some viruses. The machine says 11, but to me, it probably is like 10. Adenovirus, seasonal coronaviruses, different kinds like OC43, NL63, or something like that, lumped into one. And then COVID, of course, and human metapneumovirus, influenza A, and it distinguishes between H1 and H3 influenza A, and influenza B,
Wow.
parainfluenza, human rhinovirus, stroke enterovirus, and respiratory syncytial virus. Then there are four
Okay.
bacteria which the machine can do, which are important because these bacteria are difficult to isolate in terms of a usual laboratory culture. Mycoplasma, Chlamydia pneumoniae, and Bordetella pertussis and Bordetella parapertussis. And with the help of these tests, actually, we see that number one, problems like pertussis, which we thought not really exist, actually does exist in our
Mm.
community all the time. And
Yeah.
we have a good way of actually making a diagnosis of mycoplasma relatively early, and actually, which
Yeah.
actually shortens the course, which often is like a prolonged course of coughing. And it takes, other than using a PCR technology, it takes quite a while before we can actually make a diagnosis.
Yeah, of course. And in terms of sensitivity and specificity, they're all pretty good?
Yes, I think in the tests that we have done, we do get a lot, and I must confess, I never really tested for sensitivity and specificity. We do have situations where we find it a little bit sort of funny, but for the vast majority, I would say, from the data that they supply to us, is beyond 95% and 99% for specificity. So it is very sensitive and specific.
Yeah. And I'd imagine, as you said, like it's you're able to reassure the parents and give them an exact diagnosis so they know what to expect. So I think that would be
Correct.
very reassuring. And then, yeah, of those things that are treatable, obviously being able to give them treatment straight away again is very different to what we see in other settings. So that's pretty amazing, actually.
Yes, it's in a way it's revolutionized our practice.
And I'd imagine also it would have infection prevention sort of implications as well.
Yeah, that's true. And I think if this technology is widely applied, it would be very useful for the community to actually spot changes in the pattern of infections in the society, and thereby, if necessary, take precautionary measures to control it.
Dr. Tam, can I ask, do you know roughly how much each of these tests costs?
For us in Hong Kong, the test would cost like $2,500 Hong Kong dollars for a test.
And then just thinking comparatively of like how much a PCR costs. So that's pretty amazing again, as you said, for a 15 agent, 20-minute turnaround, and would save in terms of healthcare costs elsewhere.
I mean, in the hospital, it costs us like 4,000.
Let's jump to our first case then. So we're going to, I'm going to go through the story of Lee. And just for clarity, we're not going to use any real names or personal details about patients that we discuss in the podcast. Lee is a 7-year-old boy living in Hong Kong who previously has been healthy. Over the course of 6 days, he develops a sore throat and a cough and a fever reaching as high as 39 degrees. He sees a local doctor twice and is eventually prescribed the antibiotic azithromycin. 3 days now pass and there's no sign of Lee's fever coming down, and his parents decide to take him to the emergency room. So let's imagine you're now working in the emergency room when Lee arrives. What tools are available to you to assess and diagnose his condition? So that's for the audience to have a think about. But Dr. Tam, I'm now going to turn to you. How did you proceed with this particular case?
So, of course, we took a history. I took a history and examined the patient. And to me, he has fever, a congested throat, and also some evidence of bronchitis. He was coughing a bit, but the coughing wasn't anything serious. Okay, his nose was producing clear discharge. So the symptom would be that he has an upper respiratory infection. Of course, he's been given the antibiotics. So normally, or sort of without the help of spot fire PCR tests, and we would be doing something like a CRP and a WBC, which we have an answer in 5 minutes, 10 minutes, and then sort of decide, whether this patient needs some X-ray or whatever. But obviously, this patient wasn't actually that bad, and I think at most he would have some bronchitis. So with the help of the PCR test technology, because his history is relatively short, I think it would sort of actually change the situation.
Yeah. Okay. And so you've told us that this spot fire eventually revealed a positive result for adenovirus. I think you've sort of gone through the spot fire panel and you've talked about what those are. With regards to his follow-up, so what happened with Lee is that in a week's time, he apparently made a full recovery. So with adenovirus, given that most of the time this is a self-limiting condition, why was it important to be able to detect adenovirus in this particular instance?
So the worry obviously is that the patient's been giving some azithromycin and he seems not to be responding to it. Does he have some more serious infection, or does he have just a virus thing? And the identification of the endovirus, which we know can cause fever for up to like a week or even 10 days, and his clinical symptoms and signs all fit into the clinical entity of an endovirus infection. I was able to actually reassure the parents that, okay, he's still well. He has a slightly congested throat and nose. He's not coughing too bad. Let's give him some time. And he's taken 3 days of the antibiotic. And I would say, okay, do 5 days. I actually sort of let the patient do 5 days of that because it's been continued. I can't say that he doesn't have a bacterial infection. And therefore, we'll follow him up at the end of the antibiotic course. And in sort of lo and behold, by then his fever went down. And therefore, we're actually capable of telling the parents that there is an infection identified that can explain all the symptoms, and let's not jump into big guns or admit him into the hospital or do more things. Just give him some time.
And so that's obviously, again, quite reassuring for the parents. Do you often get the scenario where parents come back and say, but it was positive for a virus? Does that mean my child didn't require antibiotics, or does that not happen?
Right. Yes. Sometimes parents will actually mix up that viruses need antibiotics or bacteria don't or whatever.
Yeah,
So they
correct.
still ask the question, does my child need antibiotics? Or why are you not giving antibiotics or something like that?
Yeah, and it's interesting. Were there any other sort of thoughts that you had just with regards to, I guess, syndromic testing, some of the, challenges that you face?
It's important to remember that all tests have its limitations apart from its use and benefits. The first thing when we started off doing these tests, the first problem we encountered was ensuring that the clinic has a clean working environment where the machines are, because we're handling specimens. So I have to have a room which is ventilating outwards. I'm not going to spread infection inside because we're doing swabs for the patient. I have to remind my staff, we need to have a clean environment before and after every tests, and they need to wear protective garments not to get the infection themselves. Those are very
Absolutely.
important things that we have to. In the beginning, we ran tests because we do have quite a number of patients coming in, and we ran tests, and there was a day when we get the same infection for consecutive patients. And then we discovered probably it's not the real case, because we probably have contaminated a little bit of specimen in between tests, and so that the same virus turns up in every patient. So
Yeah, of
that
course.
is lesson for us to learn. We must make sure that the staff knows how to do it properly and know how to actually keep it at bay, clean, protect themselves, and protect the environment. Then, of course, not all tests are positive. Since it's been available at the end of 2022, we have done around 1,600 cases, 1,600 patients, okay? And about 85% of these patients, we found something. We found a virus,
Wow.
we found some bacteria. About 15% were negative. So we do choose our patients. We want to do this on patients with acute symptoms, respiratory in origin, fever, runny nose, coughing, phlegm, sore throat, stridor or wheezing, things like that, symptoms like that tells you it is a respiratory infection. And we got some still negative, okay? And of course, when it's negative, it's either because of its viruses beyond the panel, or it might be bacterium. It might not actually be an infection at all. So we have to actually think about other things. And the other thing is, among these positive cases, roughly 60-something% have one agent, one virus, or one bacteria identified. But 30-something%, 35% roughly, have more than one, two
Wow,
to four
30%.
agents at the same time.
Goodness.
Yes. So as PCR technology is applied more widely, we're increasingly finding that many kids do get more than one germs. And that's understandable, because in the community, in the kindergarten environment, where they usually catch these infections, it might be many other kids carrying different germs coming together in a big pool
Absolutely.
of germs, sort of sharing among
Sharing. It's
themselves.
right.
So,
Sharing.
yes, it tells you that sort of wearing masks in the kindergarten is not really very useful. And
Yeah.
we have to be aware of multiple agents that affect them. So these are the things that we have to actually be aware, and we have then to expect naturally that when you have more than one agent, the situation may become more severe, or the illness may be a little bit more prolonged. But then it helps us to understand that there are situations like this. Yeah, and we can actually manage the parents' expectation that way.
Yeah, definitely. And can I clarify as well, Dr. Tam, with these test results, they're
Yeah.
qualitative, aren't they? Okay, so just positive or negative,
Yes.
no degree of how positive or negative. Okay, so
Yes.
slightly different from PCR, where we get those CT values and we can say it's either really low, meaning high
Yes.
viral load, or really high being
Correct,
maybe the tail
correct.
end or the start. Okay. Okay.
Yes, yes. Yeah, that's true. The spot fire which we have, it's only positive negative. We used to do the biofire, which actually can give, and especially also the pneumonia panel, we can actually have a number of copies in CT values, and that would help us to identify. And therefore, it's important to realize sometimes infections that are very close in time duration to each other may actually contaminate each other. That means we're maybe testing old
Absolutely.
infections.
Yeah, no, that's right. And I think that's, it kind of comes back to, why we do medicine and thinking about the whole context of the patient and always doing, the history exam investigations and putting it all together.
Right. Yes.
Thank you so much for your time,
You're
Dr. Tam,
welcome.
and thank you for sharing your knowledge with us. It was really lovely meeting you, and I'm sure the listeners will learn heaps from this podcast.
Well, thank you.
So, Alicia, as you heard, Dr. Tam had a little bit to say about CT values in the context of PCR. So let's go into this a little bit more in detail.
Yes, so I think it is important that we understand that this is a measurement of kind of the amount of virus that is active or actively
within a sample,
being able to replicate in a patient. Am I doing this correctly? Am I saying? I'm not sure.
I know it's one of those things that we're so used to talking about that we forget. Yeah. So I had a look and just made sure that we had a good definition to go by. So firstly, CT is a cycle threshold, but it's exactly as you said. It's the amount of virus or genetic material that's available in a sample. And so what listeners need to know when they're sort of first starting out and learning about PCRs and CT values is that a high CT value is where a PCR machine needs to make lots and lots of copies to find enough of the genetic material. So in other words, if you have a high CT value, there is a low amount of genetic material. If you have a low CT value, it means the PCR doesn't need to work as hard, and therefore there's more amount of virus or genetic material. So hopefully,
I think you said that absolutely clearly. Sometimes it is hard for all of us to explain to other colleagues, and I think your definition is perfect. For more information on the basics of syndromic testing, visit the Global e-learning portal on the WSPID website, your hub for pediatric infectious diseases insight.
And that's the end of today's episode. We just wanted to say a big thank you to Dr. Tam for outlining the positives of syndromic testing. We really hope this case and our discussion has highlighted the way in which syndromic testing has changed how we practice medicine.
Whether you're on your way to or from work, out for some daily exercise, or doing the school pickup, thank you for listening to the Syndromic Insights podcast. Make sure you're subscribed on your favorite podcast platform so you don't miss an episode. Please share the podcast with your colleagues, leave us a review, and be sure to tune in next time.